Welcome back to the DermCast live drop-in studio. It's Rob Casquejo in Washington, D.C. And I am very happy to welcome back our next guest, Dr. Ginette Okoye, who's a longtime friend of the SDPA. I'm very happy to have her back today. Welcome, Dr. Okoye.
Thank you for having me. I was just thinking it's been 6 years.
Yeah, it's been a while. I think it's been longer, actually. I feel older anyway, so I know it might be longer. But I'm going to let you, why don't you tell our audience who you are, what you do here in Washington, D.C., and we'll go from there.
Sure. So I'm Ginette Okoye. I'm the chair of dermatology at Howard University. So we are a safety net hospital, and we take care of some of the sickest and neediest patients in D.C. So it's been a really rewarding place to work.
Right. Awesome. So shout out to Howard University.
That's right.
So, and you've been there a while. So, and the last time we spoke, you were there at Howard.
Yeah.
And this is particularly cool for me because you were like one of the first interviews that I ever did for DermCast.
Really?
So yeah, so this is, I'm bringing it full circle.
Awesome.
This is kind of fun. So you lectured today on a really tough condition, Hidradenitis Suppurativa. And it's really cool because we're starting to evolve some options in this space now. We're getting some help finally. After years and years of having some therapies, and now we've got some good options, some better options. So let me start this out by, let's look at what therapies have been available to us. And I'm going to talk specifically about antibiotics and metformin. These are probably commonly used, and there's a lot of questions around these things. So metformin, you talked in the lecture about using this. I think the question a lot of folks might have is, how long do you do metformin therapy? Do you see that weaning and coming off of it is a good play? Or would you rather keep them on medicine for the long term? What are your thoughts on that?
So metformin, I think, is a good option for patients to stay on relatively long term, assuming they still need it, because it not just helps their HS, it also helps with metabolic disease, it helps with cardiovascular disease, diabetes. So, you know, I think it's one of those options that helps multiple conditions in patients who are prone to them. So I tend to leave patients on the highest dose that they'll tolerate, but the lowest dose that works well. And for many people, that's around 1,000 milligrams a day, 1,500 of extended release metformin. That's really important because the extended release is much better tolerated than the regular metformin.
Right.
I do have patients who've been doing so well that we were able to decrease the dose to just maintenance with 500 milligrams a day. But there are very few patients who I would totally stop their metformin unless they had a reason to.
So, you've already crossed into this idea of comorbidities that exist with HS, obesity, insulin resistance, and diabetes. So, in the lecture, you mentioned the idea of actually screening patients for insulin resistance in the dermatology setting. And you specifically mentioned the test, mentioned the calculations that you can do around fasting glucose and fasting insulin. So talk about that, because I found that very useful, and it seems like it's something relatively easy to do at the level of clinical dermatologists.
Certainly. And I think, we have fast-paced clinics, and so it's not easy to ask dermatology providers to do even one more thing.
Right.
But we're often checking labs in patients anyway if we're going to start a biologic. And so there's a test called a HOMA-IR test, HOMA-IR. If you Google it, a calculator will come up online. It's the first option. And you plug in the patient's fasting glucose and their fasting insulin. It spits out a score. If it's over 2.5, they have insulin resistance.
Right.
It's as simple as that.
Right. Yeah.
There's a second test that's almost easier. It's the triglyceride to HDL ratio.
Okay.
And that should be less than 3. So that one you can almost eyeball.
Right, it's already in your lab profile, most likely.
Exactly.
Right.
And so, I think dermatology providers have a really unique opportunity because we see young people who are relatively healthy, who may not have a primary care person at all.
Yeah.
And so, and then people often come to us for these skin signs, skin tags, acanthosis nigricans, and they may never see another provider all year.
Yeah.
It would make a huge difference if we can diagnose this early.
I mean, I don't think I saw a primary care giver until I was maybe 30.
Right.
So, I mean, I get that, right? And we see these folks like in their mid to early 20s or even their teens, right? We know that the disease tends to present, those earlier years. So that's great. That's very useful advice. And then we can get them on to care. So we're not going to manage their their insulin resistance or the glucose intolerance, but we want to make sure that someone can manage it and get them off, take away from folks. Okay,
Exactly.
so that's great. Now, metformin, so that's great. You gave some guidelines on how you like to manage it. I think that this disease state, I think it's very easy for the dermatology clinician to look at this and be very focused on really the inflammatory part, but then we tend to maybe hyper focus on the bacterial component, right? Because as we all probably know, it's sort of a secondary issue in the process, right? It's really inflammation first, bacteria, is secondary issue. So you've talked today about the difference in the bacterial milieu, I guess I would say, in different stages, early stages of HS. So can you talk about that a little bit? How does it guide your antibiotic therapy?
To me, this was a big paradigm shift for me when I saw papers that started putting this information together. So in mild disease or in people who have no HS, you really find skin bacteria, things that should be there in the hair follicle. And those tend to respond really nicely to chlorhexidine wash or, topical bleach solutions. And, we have some new bleach waste cleansers that are great.
Carbolic acid. And,
exactly.
Yeah, right. And so this is for people who, have tendency for disease, but they don't really have active lesions.
Exactly.
Okay, gotcha.
Or for parts of the body that don't have active lesions in someone who has.
Right. So they might have
elsewhere
intertriginous lesions, but not in their armpits or their breast fold. Okay. Right. That's it. That's good. That's a great thought. Okay.
And then as you get into more severe disease, so stage 2 and stage 3 disease, now patients have sinus tracts. And the sinus tracts are deep in the skin. They are not exposed to oxygen. And so different bacteria grow there. They're anaerobes. They're the ones that tend to be smelly.
Right.
And they form biofilms. So biofilms are basically aggregates of these bugs and they secrete like a polysaccharide. They basically protect themselves from antibiotics.
Right.
And so to me, we can really pick and choose how and when we use antibiotics based on that paradigm. So in people with milder disease, doxycycline is probably going to help quite a bit. Minocycline, it's going to get those skin commensals. But in later disease, you really need to be targeting anaerobes, or you're not really going to make much headway. And I think intuitively, when we think back to patients we've treated for HS, the question is, why would doxycycline work for some people and not others?
Right.
And I believe that might be part of it.
Right. They're catching him at maybe the wrong time for doxycycline. Yeah. Okay. So rifampin as sort of a, let's say, frontline antibacterial therapy. Are you adding rifampin to things like doxycycline, clindamycin? Is it a standalone for you? Where do you fit rifampin in? Because we see that used often in this disease state.
Rifampin is getting a little tricky.
Yeah.
So one reason to use rifampin is it's actually protective against C. difficile colitis.
Right.
So that's a great reason to use it.
Right.
However, rifampin is a really potent inducer of some of the enzymes that break down clindamycin.
Okay.
So when you use them together, eventually you're on rifampin alone.
Right. Okay.
And rifampin, bugs very easily get resistant to it.
Right. Okay.
So our ID colleagues, our infectious disease colleagues, don't like us using rifampin at all.
Right.
It's one of the last drugs they have for drug-resistant TB.
Right.
So
yeah, we don't want to waste that one.
Exactly.
Yeah.
So it's really important, I think, to use rifampin judiciously and think about why you're using it. You're using it for C. diff protection, for a prescribed amount of time, but I would not leave a patient on clindamycin and rifampin for months and nights.
Gotcha. Okay. So let's move on to then the systemic medications that we have that are approved. Thankfully, this is where things have started to change for us a little bit. Where do you sort of fit these in? When are you getting to biologics? Is it a round of antibiotics for 12 to 16 weeks and all right, it's time? Or do you see them out of the gate to say you need to be on biologic? Where are you with that?
I really look at every patient individually. And to me, the speed at which the disease is progressing, a young person with 4 or 5 nodules in different parts of the body, I know where this is going.
Right.
Someone with, they've had HS for 3 months, but they already have 2 sinus tracts.
Right.
You're showing me that your fibrotic potential is high and you're going to make a lot of scars and a lot of sinus tracts in the future. So I really think about each patient, and I think about what does mild, moderate, and severe mean for that patient. And anybody who's moderate to severe, I discuss.
Yeah.
Actually, I discuss biologics with everybody.
Sure. Yeah.
I give them the whole menu
Okay.
of things that we could try. And I kind of gauge their appetite for more aggressive treatment or systemic treatment. But certainly people who are moderate to severe, and that depends. It depends on, you could have 2 lesions, but you are missing work, or you're about to drop out of college.
Right. So the psychosocial impact, where quality of life issues come in, like with any of these diseases we manage, psoriasis, eczema, etc.
Yeah.
Right. Okay. So, with biologics, do you have a problem staying within class? If one fails, stay within class, or would you just jump to another medication? How do you feel about that?
I'll usually switch classes.
Yeah.
Because now we have the option.
Right, we have an option.
Before we had other options, I would first do adalimumab, and if that wasn't working, I would try infliximab, which is the same class, but what's nice about infliximab is you can do weight-based dosing. So for our patients who were heavier, I was able to really ramp up how much medicine they got, and that sometimes made a difference. Before our newer options, I would then move on to ustekinumab. Actually, that was a favorite of mine. I think that works well in some patients.
Yeah.
But now that we have these 3 FDA-approved options, I usually do whatever's covered by the insurance, which is adalimumab usually.
It tends to work out that way usually.
Yeah.
But at least,
And then
you have data for all these. Yeah. Right. Okay.
And then I'll move on to the other classes.
And move on to the other classes. Okay. All right. And when you're on biologic, do you find yourself having to use a lot of adjunctive therapy? Let me rephrase that. Do you have any problem with openly using adjunctive therapy when on biologic?
No, I think we need it.
Right.
Monotherapy does not work well in this disease. It just has multiple pathogenic pathways, and I think we need to hit as many of them as we can.
Right.
So most of my patients are on biologics and hormonal therapy or antibacterial therapy.
So most of them. Okay.
Yeah.
That's great. That's good to know. And in terms of long-term use of biologics, this is probably true of any disease, or you can ask this question about any disease. Do you like drug holidays? Let's say someone's under control for 3 to 6 months. No breakouts or rare breakouts. Are you a fan of that? Is it something that you think might be useful? How do you feel about that?
I don't officially recommend drug holidays because we're not at a place yet, I think, with NHS where we can reliably say that someone is in remission.
Right.
However, my patients take holidays.
Right.
So
it's almost inevitable, it seems.
Yeah.
They think they're doing well.
Yes.
Yeah.
I think with chronic disease, I think people get tired, and sometimes they almost want to convince themselves that they need this medication. And so I support people through that.
Right.
Most of the time, what I've seen is slowly, as the drug works its way out of their system, symptoms start coming back, and then we just restart it.
Right.
I think there's some concern with the biologics. When you start and stop them, you could develop anti-drug antibodies.
Right.
This was particularly true of the TNF-alpha inhibitors.
Right.
But then I just start them back and I add some methotrexate, low-dose methotrexate, which can help with that. Sometimes I'll test them for antibodies to see. But I want to meet patients wherever they are. And so if they want to take a break, we'll do that and see how they do.
So in terms of using long-term antibiotics, do you have any suggestions for us in terms of helping to avoid bacterial resistance in the long-term use of those medicines?
So we don't have a lot of data to support this, but the acne data suggests that if you use benzoyl peroxide as a wash, an antiseptic wash, in concert with antibiotics, you're going to decrease the risk of development of resistance of the cutaneous bacteria. I don't think this has been tested in HS. Our patients with HS are on antibiotics much longer usually than our patients with acne, so I don't know for sure. One thing, though, this has nothing to do with resistance, but if someone is on antibiotics for a long time, they really should be on probiotics.
Right.
To one, decrease the risk of antibiotic-associated diarrhea, and two, we are killing the good and the bad bacteria in their guts.
Right.
And so I think we need to try to help people repopulate and keep the microbiome in their gut functioning.
Awesome. Thank you so much. So let's round out the conversation on an interesting topic. You talked about this a little bit, but GLP-1 therapeutics. So this is all the rage. Apparently it fixes everything. It fixes just everything. So, but you can see how, just let's say, for instance, although weight loss, it's sort of kind of here and there in terms of what weight loss does for HS. Where do you see GLP-1 therapies fitting into the treatment of HS?
I think in two ways. I think we can treat the inflammation of HS on one hand, but we need to treat the insulin resistance in HS as well, because insulin resistance drives inflammation. Inflammation drives insulin resistance. So it's this really vicious cycle.
Right.
And so I think if we use GLP-1s and biologics, we're going to get better efficacy.
Okay.
And one of the things that's really frustrating is that even with the best biologics, you know, we get improvements, but most people are not all the way better. But I think it's because we're leaving some efficacy on the table by not managing other things that are driving.
Right. Sort of clear the way for the other therapies to do their thing. Yeah.
Additionally, weight loss induced by the GLP-1 agonists sometimes will make the other medicines more effective because, you know, it's basically weight-based dosing.
Right. Pharmacokinetics. Right.
So that can be helpful as well. And the GLP-1s also block some of the cytokines that we associate with HS, like IL-17.
Right. And that's the interesting thing about it that you mentioned in the lecture, that there's actually inherently some biotherapeutic value to the GLP-1. So IL-17, and I think I heard you say that it can actually decrease TNF-alpha.
Yes, some of the cytokines upstream from TNF-alpha, so it indirectly kind of
sort of decreasing its broad reach.
Yeah.
So, and that's interesting. We know that those are players in this disease, and there is precedence for this, right? Because we have in psoriasis, there's plenty of stuff in the literature to show that GLP-1 therapeutics combined with biologic can be very helpful as well.
Yes.
So that's very interesting.
And I think, when we think about the whole patient, it's not just a skin disease. It is associated with some major comorbidities that the GLP-1s can also ameliorate. So if obesity and metabolic syndrome and insulin resistance is going to one day lead to cardiovascular disease in this patient, why not?
Right. And you may have found that they're insulin resistant if you test them, say, oh gosh, now I've got a whole plate full of problems here that I might be able to help with these medications.
Yeah, not might.
Yeah, right.
They work.
Well, that's why that's why we have them for the most part.
It's pretty amazing.
Yeah, no, that's really good. And so this is great. In the conversation of therapeutics in the space of this disease, things are happening. Yes. So we have some reason to be excited. So let's talk real briefly in closing about the future. So we've got JAKs, right? What's going on in those with those therapeutics? Anything that you're seeing?
Few clinical trials are in the works for oral JAK inhibitors and a topical JAK inhibitor for HS. So we'll see. Those haven't been released yet. So that's exciting.
Yeah.
And the JAKs are another really hot.
Are you making any use of topical JAK inhibitors?
Not yet.
Okay.
Not yet. In my patient population, it's hard to get medications off label like that, covered by insurance. But but we're excited. I'll try anything.
Yeah.
For these patients.
Hey man, sometimes it's what it is. You sort of reach around a little bit. Every now and then you find some gold.
Exactly.
Hey, we found half our therapeutics that way.
Exactly.
It seems. Yeah. Okay.
Think about minoxidil, right?
Right. Hey, there you go.
Yeah.
So, any closing comments on on your big picture of HS?
Yeah.
Where do you think we're going? Where are we? Things that you think are important for people to understand about the disease.
I think the most important thing is that this affects patients in ways that we will never understand if we don't live with this disease. And we have to take care of the whole patient and their families as well.
Sure.
And so I think it's important to think about your village, like your multi-specialty village, that you might need to employ a surgeon, a rheumatologist for people with joint pains, a psychiatrist or psychologist or therapist,
Right.
a pediatrician. I mean, it's nice to just build out a multi-specialty network so you can help them navigate the system a little bit, because they need our help.
Right. Without a doubt. It can be a devastating disease.
Yeah.
All right. Well, so this was so fun for me. And we're so honored to have you here at the SDPA as our faculty. Thanks for supporting us again. So now you mentioned that your mom played the last video we did. She played it. She still shows it to people. So no, I'm going to make sure she gets this one. I'll send it to her directly. I'll find out.
Will do.
Yeah, I'll send it over to Howard. I'll make sure. I'm going to make them put it up on their social page. You're going to be insta-famous.
She'll love that.
Yeah, that's great. So thanks again, Dr. Okoye. It's such a joy to sit with you and share your passion for these diseases. Thank you.
Thank you. Happy to be here.
Okay. Thanks for watching the DermCast Drop, and this is Rob Casquejo in Washington, D.C.